we'll do it. Okay, it's all right, it's all good.
We'll get back to the.
So go share files again.
Okay, so keep bearing with me because all of this technology is new. So thank you for taking the time to tell me about each of you. I know that that's time out of the class, but I promise we'll fit things in. I think it's really important that you all know the resources that you have in the class together, because I was just jotting down where everybody has worked, what their background is. Usually as an RN, what your background is, it's what you're most passionate about. So we've got like trauma, cardiac, pediatric, postpartum, like we've got people from a lot of different. So if you're struggling with a concept, because like cardiology is not my like jam. So when we're doing the cardiology section, I mean, part of this course is not to just like PowerPoint you to death. It's really about like, let's share real life experiences with patients and what does the life of a nurse practitioner look like and what's actually going to be valuable to you as a future provider. So I'm going to use your expertise in the various areas because there's no way that as any instructor can be an expert in all of these areas. It's like impossible. I don't know. Maybe there's someone out there, but so I am a nurse practitioner. I'm a yoga instructor. My passion is women's health. I was in family practice and practiced as a primary care provider for 10 years in New Mexico, first actually in Michigan and then in New Mexico. And then I moved here 2 years ago to specialize in sexual medicine. Worked for Banner, have left Banner, and now I'm working back in private practice, which is where I love private practice. Family private practice. The hospital systems need to be there, but for me, that's my jam. This is my husband and my 2 kids. They are like my world. I only have 2 of those dogs. I'm not crazy enough to have 3 dogs. Although if you have 3 dogs, bless you, love dogs. And then we have our lizard, Kiwi, is my son's, and he takes care of them. So to get into the course, if you guys have questions about me at any point, let me know. I've been a preceptor when I was a nurse. I was a preceptor for nurses as a nurse practitioner. The entire time I've been a nurse practitioner, which is 12 years, I've always precepted students. Done some like course like work, but this is really the first time that I'm delving into being in the classroom. So if there are things that aren't working for you, if you have concerns or anything, I'm super approachable. So please let me know. If you feel like you're not getting out of the course what you're wanting to, don't hesitate to let me know. And we'll try to figure out how we can get you what you need. So kind of overview of the course. And I think all of you have been in a course at the University of Phoenix, which is awesome. It's not like this is your very first class with the program. So you all know how to navigate these things probably better than I do. So if you have questions, I have Linda, who's been doing this a really long time, so we can always find answers for you. But there's the grade book. We kind of talked a little bit, I was mentioning about being at home and just the difference of being at home versus being here. You all know what type of learner you are. So if you're a learner that can learn at home and not be distracted, that's fabulous. Or if you're a learner that like has to be at home because coming here isn't an option, just make sure that you're giving yourself the environment that you need to learn. And if you're here, same thing, like whatever you all need to learn, that's, you know, your strategies. We're gonna try to incorporate some videos. We're gonna try to incorporate some exercises so that way you guys will be investigating things during the class. Because I know everybody has some auditory, visual, like it just depends on your learning style. So we'll try to incorporate multiple things. There are study guides available for you within the course content. The assignments, I'm not sure if you all have had to write an APA format at this point. I think we do that in nursing school too. I mean, APA is like, whatever. My kids are using APA in high school. So if you have questions about formatting, let me know when I grade the assignments. If you put effort in, that's what I'm looking for. I just want effort because the effort will hopefully, like my goal is that after this class, you know, you have enough knowledge to pass your boards because that's really, you know, to me, it's really practice that makes us amazing nurse practitioners. It's not so much the course content during our program, but you have to do the course content to pass your boards in order to actually be a nurse practitioner. And I will say too, like just as an introduction, like I love being an NP. Like, I really liked being a nurse, but I love being a nurse practitioner. It is so, it's rewarding in the way that being a nurse is, but kind of like next level because you are the provider. So you're really where everything stops. Like, you get to make your own decisions. You get to practice autonomously, and it's really awesome. Scary at first, but that gets better. So, and then there are animations and videos. The introductions took a little bit, so I don't want to take time out of the course to find those, but I would encourage all of you to look at the animations and to pull up the videos, because they, in like 3 to 5 minutes, like really put down, like, this is what you actually need to know. And the University of Phoenix is the one who collected those videos, so they're kind of like the best of the best. And if you are struggling with a concept and you're like, hey, Melissa, I'm really struggling with this concept, we will find videos, we'll find resources together to try to help navigate that. And then I'm not sure if everybody saw the announcement, but I'd really like to, as part of the participation, part of your participation is definitely being here, and I appreciate like everyone is here tonight, which is wonderful. But part of the participation is trying to find an article it doesn't have to be anything crazy. Like, I don't need you guys to, this should take like 5 minutes, like nothing longer than that. But I think it's really nice to feel out, like, how does genetics and immunity, what is happening in the world that's relevant? Because as a nurse practitioner, no matter what field you go into, your patients are going to be asking you. I mean, if you go into cardiology, they're going to be asking you things about like women's health, I mean, potentially. So just having a feel for what's going on in the greater context is really important. It's not going to be graded. We're just going to, like, it, depending on time with the content, I might ask a few of you if you brought one to kind of share what you brought, and then that way we can all benefit from the information. So conceptual pathophysiology, it's really more about understanding, which I would say when I was in patho, it was not. It was like, memorize this stuff, like, don't really know how it fits into anything, but this course is more geared toward how is this going to fit into like an actual human that's standing in front of you, and what might that look like? And then really a case study approach. So there'll be case studies throughout the class, which there'll be like 20 minutes for you guys to kind of work. If you're here, and feel free, like if you're at a table together and you guys want to work together, I'm totally down with that. I think that's a really nice way to work. If you're at home, you have to work by yourself because you're at home. And then kind of learning by teaching. And so that's a reason for the case studies too. You kind of do the case study, you're going through those, through the cases, and then teaching back with like telling us like, what did you come up with? What are the answers to those things? Rather than me just, again, like PowerPoint of the information. Are there any questions? I want to make sure that people at home, because we're kind of gonna jump in a little bit.
What do you find the animations?
So the animations are going to,
Is it listed in there?
it is. So if you wanna, I can definitely share my,
Just
Under the learning,
just
under learning
activities.
The learning activities, yeah.
under learning activities. And then under the learning activities for week 1 is where you go. And then it'll say, it's kind of a little confusing because it's right after chapter 30 and it says pathophysiology animations.
Okay, I see that.
And then so you can click on those. And then there are also the digital toolkit, which will bring more information. And then if you click on at the very bottom, each individual genetics, immunity, infectious diseases, those are where additional videos are. So, you know, for study purposes, depending on how much time you're taking every week to study, I would incorporate like an hour of your study time into just going through those, because they worked hard with other instructors to come up with what would be the best for those things. And if anyone at home has a question, I'm trying to, will we have access to the PowerPoint? Yes, you will totally have access to the PowerPoint after class. Marlena, is your camera still really blurry? Is everybody's camera really blurry? Do we need to like clean the screen? Let me know if anybody else has a blurry screen.
Can I just make one little comment? So I was the lead faculty for patho for 10 years, but that was like, I graduated from this program in 2002. So I know exactly the curriculum, been through the same thing. It was 3 years long, but I can't tell you how important patho, farm, and physical assessment, your next 3 classes, this one, farm and physical assessment, are the 3 hardest courses. The content is unbelievable, and you cannot expect to pass this unless you put the time in, because if you don't have a strong sense of patho, you're not gonna understand pharmacology, how the drugs work, how the defects of the patho. So these 3 classes are what it's gonna determine whether you move on. They're that rigorous, but they're so interesting, okay? So really give it your time, okay? These are the 3 core courses now. This is where the rubber hits the road, okay? And if you're thinking you can cruise through it, it ain't gonna happen. So really focus, dedicate the time, and I'm telling you, it's interesting and it's fabulous, okay? But that's the real world, okay? And when you get your residency, which is, after pharmacology, what I found is, everybody flies in from all over the nation and we check you off, and a lot of people don't know basic anatomy. They don't know what the deltoid is, they don't know, and because they, it's basic anatomy. So really, give it your all, give it your all. This course needs every mitochondria that you've got, okay?
Yeah, and I'd add to that too, study the things that you don't like more, which is hard, because the things that you like, you're just gonna retain better as humans, is what we do. So as hard as it is, study the things that you don't dig as much, and that will serve you. So genetics is kind of like, again, each of these subject headings could be, it's, a full year-long course, if not longer. So the things to know and to dig into a bit deeper are, and someone had asked on here, but these PowerPoint slides will be sent out. So some of the slides are more, these are the things that will potentially be on boards. These are the things to dig into, to learn more about. And there are also aspects that we'll do the case studies on. Genotypes, what makes up our genetic makeup. Phenotypes, our expression, transcription, the mutations that can occur. I will say that within the field of being a nurse practitioner, genetics has been more in the forefront because of COVID and the link of how does that virus, what impact does genetic makeup, and does the genetic makeup of each of us as individuals, how does that impact how COVID impacted families, individuals? So in terms of, if you did do the article review, I'm sure that you probably found quite a bit related to COVID along with other diagnoses. Genetic conditions, specifically like cystic fibrosis, sickle cell, I'm sure that you've all seen that in the hospital setting, no matter what hospital setting that you've been in. And then understanding how those conditions impact care. Like in cardiology, how does someone coming in with a specific genetic condition, how does that impact how you manage them from a cardiac perspective? Inheritance, how do we inherit our genes? And we'll talk a little bit about that in the next slide. And then also autosomal recessive and dominant genes. So, and again, these will all be sent out, but we know, and this is kind of really like backing it up to basic understanding that you all had in your nursing program, I would assume. And this is also things that are taught sometimes at the college level and high school. We know that autosomal dominant, an unaffected parent, and an affected parent, and then that traces down and how that impacts their offspring. And then autosomal recessive, that you have to have both, and then how that trickles down to the parents. So this would be something that, to study this, because likely there's going to be something like this on boards. They tend to ask questions that seem very tricky, and they're really not. Like, they're actually really straightforward. So also not complicating something that's really a simple concept, and understanding it at its most basic level is really important. So genetics. And these are questions that I'd kind of like us to explore, because I want you guys to be involved in the conversation. Can anybody give an example, like why genetics is important? Like why is that kind of part of the curriculum as you see it? And I'd like everything to come at the perspective of your nurse practitioner, because that's really what we're going for.
For cardiology, it's important for us to know kind of their family of heart disease. Because if their mother had it at 40 and their father 65, grandparents, usually it comes down. I mean, we kind of try to make people laugh a little bit like, you didn't get good genes. I mean, you have like Gloria Vanderbilt genes versus, nicer ones, because it's mostly with heart disease, it's genetics.
Yeah.
I mean, I've had people come in and they run marathons and triathlons and they're the healthiest person you see and they're getting bypass surgery. And then you see someone that's 400 pounds and, and diabetes, and I mean, all the comorbidities and their corners are pristine. Like, you're like, I hope mine look like that. It's not just about diet and exercise and nutrition and all that. It's genetics. It's literally genetics.
Yeah, absolutely. Annette.
For me in dialysis, kidney disease, genetic play a big part of it. If we have people with stenosis and that has undeveloped kidney, one is smaller than the other. We also have atypical HOS, and we find out which one, if they have a pre-genetic disposable to that. So genetic play a big part on health period. So we do see impact in kidney kids also, in kidney disease period. And then the older people probably didn't realize that, but genetic play a big part of their kidney.
Absolutely. And so that's kind of goes in a little bit to how genetics impacts our health. And then how about like families? Like, can anybody give an example?
Well, and I was thinking about how far we've come in genetic testing, and like I know that All of Us program that they're probably running at everyone's hospital, right? Like I participated to get $25 cash, but like they take your blood and then like they've had so many people doing it. But anyways, to know that you have the genetics for like breast cancer, they know that there's this like very high, like likelihood, right, that if you have those genetic markers, like, the BRCA or whatever they are. And so people can start doing preventative things earlier if they know that they have that, So I don't know if that's what you meant, how they're affecting families, but that's actually the article I looked at was about the case example is breast cancer and like all the research now that's being done, like All of Us research and how much more information they're getting and how helpful I think that will be in preventing cancers. Yeah, it's just coming a long way, but I think we're like at the cusp of it. It already has come so far, but I think it's up and coming really.
And no matter what specialty you guys go into with the testing, it's very challenging it's really important that nurse practitioners are the ones that are offering the testing. It's a lot of times we're first line that are seeing patients first. So we need to know which testing is appropriate for our patient population. If you go into primary care, absolutely offering that to appropriate patients. And then also understanding that unless you go into genetics, which is amazing if that's the thing that you want to specialize in, having those patients see a genetic counselor is really important because it is so cutting edge and there is so much to know that your patient's going to have this information in front of them and potentially be very scared by what they are reviewing. And so having that appointment or that referral, and a lot of times the companies actually have a genetic counselor that's available as part of the testing. So really encouraging the patients that you serve to go that next step. Again, because it's really impossible for you to know everything about that test kit because it is so complex.
It's interesting. I work with a nurse and her and her husband are looking to have children. They did genetic testing and her husband's completely clear and she had like 3 or 4 genetic anomalies that were in their history. But they said because you're talking about the dominant recessive, because he doesn't have any, it's okay that she has them because they're not going to follow through. So it's interesting when you hear that. And then a friend of mine that works at St. Luke's in St. Louis with me, she had that marker you're talking about, and she decided to do a double mastectomy and a complete hysterectomy.
So there are a lot of factors that go into knowing that information. You have one situation where it actually ended up being something that was hopeful to them because they were like, okay, you have these genetic markers, but it's fine because we ended up together, so our kids won't have that. And you have another where that's its own, ethics and other things that are involved, that we're removing body parts because of being fearful of that. And it's fine. I mean, we meet people where they're at, whatever they need to do,
Her
but
mother
it's.
had it and her grandmother had it, and it was this kind of like.
Is that Angelina Jolie? Is that what she did?
Yeah,
Angelina?
she did.
That comes to mind, yeah.
I think several people have done that.
Several people, yeah.
Yeah.
And I think
Just because they have the marker,
Well,
and
peace
I
of
don't know
mind,
what I would do.
right?
I just, yeah, I don't
Peace of
know.
mind,
I would probably do what she did.
I don't know.
Yeah,
There's implants and, adoption, there's this, versus the option of having breastfeeding.
And that's another piece of, being a nurse practitioner is allowing patients, giving them all the information and then letting them make the decision. It's not our decision. It's really their decision, what they do with that information, but also counseling them that with genetic testing, that they even want it. Because it's also okay not to want to know, right? But knowing what you can offer them. We kind of talked about that. And then, in terms of how genetic diseases are treated, what have you all seen? And anybody that's at home too, please feel free to participate. But anyone that can speak to what genetic diseases you've seen and how they've been treated in your setting, if any.
So when I worked in surgical oncology, I've seen a lot of patients that come for themselves and like for the breast cancer with the BRCA1 and 2. And then you see the mother come in and then the daughter will go get tested as she has the genetic markers too. But then she will do the surgery and then a few months later, you'll see the mother being the support system for the daughter who is going to go through the same mastectomy bilaterally or with hysterectomy, either or.
Yeah, that's a great example. Thank you. Absolutely. And then how about, we kind of addressed that with like the carriers and inheritance and what that might look like in the fields.
It was just interesting that she had mentioned that. I was like, oh.
Yeah.
But I guess it's peace of mind that we want to bring a child in that have all these genetic anomalies.
And I think moving forward, we're going to see more of that because a lot of the testing is now covered by insurance or mostly covered by insurance because it's been around long enough. And so some of it is not. There are some newer screening, like Gallery is one that's like preventative. Like it's like before you would even know that something is going on in your body. So I think we're going to hear more stories of that, of people making decisions based on their genetic screenings because they're going to have it done because it's affordable.
And I think these research groups too, who are offering it for free, then you're starting to see like people have these results that they're getting, for free and coming to you like, hey, I have these results, what does this mean? And
Yes.
what do I do? And I think the biggest thing as a nurse practitioner is just support and resources. Like where can you then point them? You know what I mean? Or what can, like you said, genetic counseling and.
And if genetics is your thing, then that is definitely a growing field. So always job security as a nurse and a nurse practitioner. And then just in terms of if anyone has seen genetic mutations at all in your practice and how that can relate to disease, infection. Anybody think of how you might have seen that or how that might play out in practice?
I mean, we get babies born with Down syndrome and then go to see cardiologists and have heart surgeries. There's a couple other genetic disorders that babies are born with as well. Down syndrome is the most common one.
Absolutely. So we see that probably, a decent amount. You'll see that potentially more in pediatrics because that's where those genetic features might display themselves earlier, either in infancy or in childhood.
And I would love to know, like, in cardiology, do you guys see genetic disorders? I don't know what adult genetic disorders look like.
Babies is what I say. No, there are anomalies, but I don't know if they're genetic. I guess it could be. But when you look at the coronary system, I mean, you can have anomalies where the circumflex comes off the right coronary artery, or they'll have what they call a double barrel where they're not even connected, they're just two different systems. Some people have an extra ramus.
So kind of like structural
It's
abnormalities,
structural abnormalities.
whether they're genetic
And their
or
heart's
not.
flipped, or they have Kawasaki's disease, and when you look at their, and that was the most interesting thing to me, it was just, it looks like they have like aneurysms all through their coronary arteries, and it just looks ate up. And some of their vessels are huge because they're so dilated. And it's just, and they do well with it, so it's interesting.
And medicine is pretty awesome. Help a lot of people.
I guess that's kind of mutation.
Yes, thank you. So kind of moving into immunity, a bit of a group activity. So we might take, I wanted to let all of you know at home too, we'll take a break from 7:30 to 8, just so you guys, I should have started with that so you knew when you get a break. And then we'll kind of wrap things up about 9:45 just to answer any questions that you all might have. I really respect that it's super hard to sit for more than, I think 2 hours is like the max that I can personally sit in one place. Just so you all know that that's when the break is gonna be. So go ahead and take some time if you're at home, kind of going through these questions. And then those of you that are here, again, if you want to partner up, if you wanna do a group of 3 and a group of 2, that's completely fine. And like really like, open up your book, find where immunity is, like really like dig into some of these questions. And I would say like, we'll just do that for about 10 minutes. We don't go all the way through, that's totally fine. And then we'll come back and then I'd like us to discuss things for 10 minutes. That way we can provide feedback and information to each other as well. And I think that those of you at home probably have access to the rest of the PowerPoint too. So there's a little bit in the PowerPoint, the next slides. So if you want to kind of challenge yourself and do more learning, then I wouldn't go ahead in the slides. And then we have slides on this as well. So for you guys here, you'll have access to the slides too. So any questions about that from at home or here?
I think there are other teachers, but maybe you don't want us to see ahead, but it's nice to have it on our computers, like unlock the PowerPoint like before class so that we had access during class. So there's a way where if it goes into the same spot where the learning activity,
Right.
maybe you like to do it after, which is
And there's some slides that we don't want to show you yet because they're part of the, so that's why we're waiting till afterwards. But you're right, there's some weeks where, we'll post it in advance, probably like with, preparing guys the answer, I think we can have it ahead of time, but,
And we can definitely, I'm not wedded either way.
Okay.
So if
the
there's like
genetics
more.
one was small and hard for me to read, so I was wishing it was in front of me, but like it's fine.
And if there's more of a consensus to have it uploaded, it's fine, like I can upload it for there's basically gonna be a Google Drive for this class.
Okay.
So I'm actually gonna post it to the Google Drive and I'll give you access to the Google Drive tonight.
Okay.
And then so for like weeks coming forward, I can absolutely post it right before class and then you can get it on your drive. Yeah, cool. Yeah. Feel free to talk, like those of you that are in here.
Are you able to make that any bigger? I know that's hard for me to read.
I know what it is.
you know what, that is full, well, actually, you know what?
I don't think it's full
Plus-
size.
Press the plus up there above.
How's that?
You guys are young. Younger, eyes.
I'm with you, I can't see anything, is that better? Oh, did one of you guys have a question?
Yeah, I have a question because I was reading these questions here about immunity and adaptive immunity. So I want to read about this and then we want to comment about it, or do you want us to do something else?
Yes, so kind of looking at this slide that's up on the innate and natural immunity and then adaptive immunity.
Okay.
And just kind of a brief, like, information on those items and then we'll go over it together, please.
Okay.
So you have about like 8 minutes-ish, like pretty much until like 7:10, and then we'll
Okay.
come back together.
Okay. Thank you so much.
Yeah, of course.
which increases your immunity versus
Oh, it's been a while. I gotta turn my volume up,
There we go. Okay, we're back and can people hear us or hear me? Awesome, thank you, Andrea. Thank you.
It's just easier for me to.
Okay.
So let me look into that. And then look into
Okay, so it is totally fine, you didn't finish, we're good. I think we're probably gonna kind of share a little bit, go through the slides that relate to this, and then that'll probably take us to about the time for the break. Does anyone at home or here, if anyone that's online would like to participate, I'd like to give a minutes to Elizabeth. Yes.
Yeah, what I read is like the innate immunity is the one that we born with it. Let's say, and we born with this immunity, and how the body protects us is, let's say, with the skin, which is our first defense, the mucus in our system, and another things like inflammations or situations that the body tries to protect us. And the acquired immunity, this one we obtained during our lifetime, let's say through vaccinations, or also if we get exposed like infections or something, it gives us more immunity. And we start getting this defense for the second or third time if we get infected again. I will think like kind of with the COVID vaccine. You know, we got immunity with the vaccine, but even if you wasn't vaccinated, if you get it one time, maybe the second time is not too rough in your body because then you have this immunity already in your body. This is what I learned. I don't know if it's too.
Yeah, that's great. Thank you for sharing, Elizabeth. That's awesome.
Thank you.
Anyone else from home? Oh, good. Okay. Anyone? Anyone here want to share anything in terms of advantages, disadvantages of either one, if you got that far?
I think disadvantages of innate immunity can cause complications such as people that overproduce hemoglobin, they can get more clotting. People that have platelets, scarring can get keloids. The body overproduces that scarring mechanism. Anything that would overproduce, if the bacteria would get disbalanced, it's supposed to be balanced. If it gets balanced, it can cause more problems.
Mm-hmm.
That's what I would think of disadvantages of innate.
Mm-hmm. Any disadvantages for acquired? I mean, more straightforward.
Can you repeat the disadvantage for in?
So disadvantages for innate, that the body doesn't always do what we want it to do. I think that Danny posted a link. We'll follow it. So that's a great link for those people that are in the chat. And then Danny, I will also share that with everybody here. Let me see if I can share my screen. I think I can, so give me 1 second. I'll get better at this, but for now you guys all just have to bear with me. So this is the website that Danny found, and it's great. So I can maybe send this out as a message for the link for everybody that's here, and then anybody who's at home, you can kind of copy and paste it. So the difference between innate and adaptive, and kind of breaks it down really simply, which these are the things that are gonna help you the most, right? Like, these things get so complicated so quickly that if you start going down the rabbit hole, bring yourself back to something like this and be like, okay, I went down the rabbit hole, now I'm bringing myself back. And so within this, obviously with innate, it's pretty fast, and adaptive immunity tends to take longer, right? Because you think about vaccines, colds, like all the things around the environment that it usually takes some time for that immunity to build up. So this is great. Thank you, Danny, for sharing. I love this. When you guys have things to share, do not hesitate to bring it to our attention. I'm trying to follow the thread too. Okay, let me get back to my files. Any other thoughts or on those questions specifically? I think that resource that you found, Danny, really highlights what those questions were asking really well, so thank you. Okay, so kind of moving forward in the PowerPoint, this is also a really nice table that will be in the PowerPoint slides for you guys, kind of talking about naturally acquired, active versus passive, artificially acquired, active versus passive. So again, really keeping it at that level and not going down that path where it can become really, really confusing and really, really dense material. The different types of immunity, again, natural immunity, and then within acquired immunity, actively acquired, an immune response, vaccine, or an active disease, which again, like, we kind of live in a time where it's a bit more simple to understand those things because of COVID, right? I mean, we've been living this for 3 years now. The debate about the vaccine, the debate about getting COVID versus the vaccine, the boosters. As a nurse practitioner, that's going to be a huge piece of your role, again, is going into every patient room without judgment. To me, what makes us special as providers is that we were nurses. Like, I love that all of you have been nurses for like a decent period of time. Some of the other universities I've worked for, people were going straight through, like for their doctorate without having any experience as an RN. And I think that that's too bad. Like, you're missing a huge piece of what makes us as providers so special is having that experience. So you're going to be able to go into practice understanding the impact of COVID because you saw it in your patients. It didn't matter where you worked at. And you had patients that elected not to have the vaccine, patients that elected to have the vaccine, and their experience all the way around. So that's really special and unique that you all are going to be bringing to practice. That is going to be so beneficial to the patients that you see. So actively acquired, sometimes that's lifetime protection, sometimes not. We're also experiencing that. Like, we have a vaccine and we're like, we don't know. Like, we need months of boosters because we don't know. We're trying to figure it out. And can usually take about 1 month between onset to like being fully protected. And then passively acquired, you think about like women's health, like breastfeeding babies. And then there's that whole picture of what is the impact, what are the benefits of breastfeeding, how do we reproduce that in formula-fed infants, things that we're continuing to work on. And then that can happen obviously within an hour. If you think about the first feed that a baby has, that can provide some really protective immunity for those babies. And they also do fine without it, so it's all good. And then the immune system itself, compromised of lymphocyte B and T cells. They do have memory. B cells produce antibodies. T cells just attack directly. And a good example of immune system response that we've had over the course of many years would be like HIV, right? And how the T cells are impacted.
That's what I thought, HIV was T cells.
Yeah. So when you're studying, again, if you're reading something, if you can link it back to a disease process or something that you're really familiar with, that will really help your brain to be like, oh yeah, like T cells, HIV, like, and putting those links together will be really, really helpful. And then just the immune response, how we respond and develop immunity, that initial exposure. And to remember these things, I would say that even if you're not necessarily a visual learner, I would get those charts and tables and even like make your own drawings, even if I don't draw well at all. But when I was going through school, I made lots of really horrible drawings. And it really helps to like, when you're taking your test, you can like see it in your brain, the drawing, instead of just like, again, just bullet points. So consider how you can even make these into drawings and grids. IgM is produced in larger quantities, IgG in smaller quantities. So can anyone kind of think how you might test these things in clinic, like what you might see if you worked in a clinic as a nurse practitioner? Or maybe you've seen this as a nurse.
What about like doing blood typing and immunity and for certain, like the IgMs and so forth, because sometimes if someone has a specific response, you have to further test.
Yeah.
And they can't get the blood because they'll have a reaction if they don't.
Yeah, and that's
Even
like
though that's
more
too
advanced
bad.
testing. Yeah.
That's one thing I can.
Food allergies are huge right now.
So that's what I was thinking, and you guys will see that in practice if you work. You will likely have a preceptor that you'll work with in family practice, and so you'll probably see allergy testing. So having some familiarity of like, am I looking at IgG, am I looking at IgE, and what does this mean? Does this mean that they're having more of an allergic response, and what's the level? There's more and more of that in our culture. The food allergies and also the environmental allergies. If you work in dermatology, they do a ton of testing, obviously, because, rashes. I don't know, I think we talk about derm, but we talk about rashes forever, like the bane of every provider's existence, unless you're in derm.
There's never an answer.
There's never an answer.
There's never.
It's very sad that I don't think of the basic thing, but I don't ever work with like, I'm not exposed to any of that.
Yeah, and that's like totally okay. And I think that that's the other piece that's really a beautiful thing about nursing and a beautiful thing about being a nurse practitioner. Now we're everywhere. Like you can be I'm a sexual medicine NP. I mean, when I started, that wasn't even a thing. It's barely a thing right now. Like I'm helping to create it into something bigger. So being a specialist is becoming more and more prevalent. I will say that if you know what you want to do, do it. But if you can be in family practice or some sort of general medicine as a provider for a period of time, it gives you a really nice base. It's just like nursing, right? Like most of us go into something a little more general and then we kind of niche down. And it's the same thing as for being a nurse practitioner, because when you're in family medicine, you're doing all of it, like everything. So you have to know enough about all of the different pieces. I mean, it's similar to patho, like you'll have exposure to all of these things in a variety of ways. So this is just a difference of what happens when you have a primary response versus a secondary response. So you can see just like the IgM kind of like peaks and then goes directly back down around 2 weeks, and then IgG, is going to stay high and provide that continued response and immunity. Trying to think how I'll keep going here. And then humoral mediated immunity is where the B cell is really in charge, occurs when the antigen binds to the B cell. There are some really good videos where you can watch this happen. So take some time when you're studying, again, to watch it happening, draw a picture if it helps you, and then that way you've got the video, you're drawing with your hands, and then you have it also written out. That'll be really helpful. And then again, IgA, IgG, IgM, IgE, IgD, I would say that unless you go into immunity, like it's okay for you to have a pretty basic knowledge of this stuff, because you can again go, I mean, they're immunologists for a reason. Like, this is what they do. So if somebody comes in and they're very complex, that's who you would get them into. So function of IG, neutralizes bacterial toxins, neutralizes viruses, opsonizing bacteria, phagocytosis. Phagocytosis is definitely something that you'll review further in your textbooks. And then just kind of like activating that inflammatory response, because inflammation isn't necessarily a bad thing. Inflammation is really complex. Sometimes it can go to the point where it is negatively impacting the system and the body, but it's also very protective, because without an inflammatory response, we would become very, very ill. So it's also very protective. It circulates until it finds its match, and it's one of several defenses: agglutination, precipitation, neutralization. So just, it's a very important part of how we form an immune response and of that whole picture. These are, again, like, I think the most important thing on this slide to know is really IgE, right? Because IgE, what you're gonna see in practice and what's gonna be the most prevalent as a nurse practitioner is allergic, any sort of allergic response. So when you see IgE, just think allergy. And you know, some of these, like IgD, never seen that in practice. Like, I mean, it's here, but like I've never seen that in practice as something that I was looking at. And then, so in terms of how it's useful in practice, again, we were kind of talking about, as a provider, you have to know about medications, and that's what Linda was talking about the connection between your, physical assessment, pathophysiology, and then pharmacology. Like, they all go together. Because if you don't understand the impact that IgE elevation has on the body, then you don't understand that Xolair blocks IgE, and that's why you're putting your patient on it, right? So it's really nice to understand the mechanism of action of a medication by understanding what's going on in the body. And then you can also talk to your patients about that too, which is nice, because they trust you more if you have something to say about the medication that you're giving to them. That's the one thing that separates nurse practitioners, I think, and what I hope for you guys is that we don't just like, we hopefully aren't just like, well, you'll just take it and I have 5 minutes and see you later. It's like you actually sit down and you're talking to them about, this is why you're going to have this response with your allergies. And then measuring IgG and IgM might tell us more about active or latent infection, and that's what that diagram is. And then we kind of talked a little bit about vaccinations as well, and how important they can be in supplying us with immunity, particularly in the world that we live in right now. So I think, because I'm like big on respecting time, and we'll start on time in the future. So sorry, we got a later start today. So let's go ahead at 7:30. We'll break until 8 o'clock. And then again, we'll pretty much run from like 8 to 9:45. So it'll be a little bit longer than this duration. And then we'll kind of go through the rest. There are about 3 activities moving forward. So I'm trying to figure out how to break this into breakout groups for the people at home, so you guys can have the same experience and actually be broken up into groups so you can work together. And then we'll do the same thing in here and have breakout groups.
Can I ask something? Did you do breakout groups in your previous courses?
Yeah.
Okay.
Eric would break it out somehow.
Sure.
On there.
And I've got it on my computer, but she has a Mac, and so I don't know if that's.
I use a Mac, but I don't know how to do that.
Right. She's got the tab on, so we're waiting for an answer back
Yeah,
on that.
that's all I
So,
have.
all right.
We had a Mac, she broke them out.
Eric,
What's that?
Veronica did.
has a Mac and broke them out.
Yeah, I think it's just that I don't have access.
We'll get it figured out though, and then we'll get you guys into breakout
I doubt
groups.
it's a Mac issue.
Any questions from the people at home? If you guys have any questions, I'm gonna turn off the sound just until 8 o'clock. If just one person can let me know if you guys can hear me.
Yes, we can hear you.
Okay, so we'll go ahead and get started again. We did have a question from Brooke about what I do, and my role is sexual medicine. So basically sexual medicine is kind of a new branch under the umbrella of women's health, even though we were talking over the break about the fact that as a family nurse practitioner, you can really pretty much do anything that you want other than, you know, doing the ICU. Like if you went into the ICU, you should really be in acute care. And it really, when I graduated, you could literally do anything because acute care wasn't an option. But now if you wanted to do ICU care, that's really what you would need to do. But as an FNP, you can go into pediatrics if you want to go into pediatrics, go into women's health. So in sexual medicine, what I do is management of like pretty much all,
If you had two.
Linda, we're starting, sorry. All vulvar conditions, so like vulvodynia, vaginismus, and when we get into the women's health section, I think we do a little bit on gynecology in this section. I'll kind of talk about those conditions. All dermatological conditions like lichen planus, lichen sclerosis, those sorts of things. Management of all hormones, so endocrine is like when you talk about cardiology, like endocrine is like, I love hormones so much, like all the hormones, all of them. Because everything comes from, you know, cortisol and insulin and estradiol, all of them are amazing. So I do all of that, and then also management of like PCOS, thyroid disease. So all of those things are kind of like combined in sexual medicine. And a lot of it is the pelvic pain conditions, right? So not that I manage endometriosis, but I'm sure you've all heard about endometriosis and have patients with endo, know someone who has endo. And so sexual medicine, we're the piece of managing the hormones and the vulvar conditions that are related to it.
So what's different from sexual medicine and women's health?
So I would not go to a women's health provider to manage my hormones if I were perimenopause. It's a real specialty.
Yeah.
Like, I mean, there's a lot of just like putting people on oral estradiol, which you shouldn't do, or just birth control, which is not a great option. I mean, it can work for some people, but women really need to know all of it, like what supplements could they use, what lifestyle modifications, and then really knowing the hormones. There's a lot to know about the types of estrogen and how much progesterone, when is testosterone indicated.
So is this like a hormone center, but like you think it's like, I'm very familiar with like these hormone centers, and a lot of times it is nurse practitioners, not thinking about it.
And sexual medicine is more also incorporating the vulvar conditions.
Rather
a lot
than
of
just hormones, we also do.
So we'll get patients that have never had intercourse and then they are married and they can't have intercourse because it's so painful. And that's vaginismus, right, or vulvodynia, vulvar vestibulitis. And so we help women manage that. And it's actually more prevalent than you would think. I mean, we're really busy.
So you're not just at a hormone center, it is actually like, because obviously they don't do that aspect of it, you know what I mean?
Yeah.
But
So if you're doing
hormones,
sexual medicine, like
it's everything.
as the umbrella, it's part of that next. So you guys can definitely like look up sexual medicine because it's definitely.
I haven't read it.
And Banner just started one of, you know, I think there's only 2 or 3 fellowships for physicians too. So there's now a fellowship in sexual medicine at Banner.
Wow.
Or Southern California. So if that interests you, just so you know,
Never
like
thought so.
you never know. If you're interested in something, like keep following your passion. So it's
I don't
Just out
know.
of curiosity, if someone did have a inspired hysterectomy, I mean, they don't create any hormones, correct? Like no testosterone, no.
you can still create some estrogen and testosterone because estrogen is also created in the fat tissue. So it kind of depends on your body habitus. And it's the same thing with testosterone because testosterone is muscle fibers. So if you worked out a lot, you can produce your own endogenous testosterone still. Probably at lower levels, but yeah. So you can absolutely still use some of your own endogenous hormones.
Even though you don't have the actual organs.
I wouldn't recommend not using the supplement, but you could potentially produce some.
Yeah, I definitely need to go get some.
So anyways, it's like interested about
Fascinating.
what I do. So if you have any more questions or people at home, like, don't feel free to message me. Cell-mediated immunity, the different types of T cells, cytotoxic, T helpers, T suppressors, and then delayed hypersensitivity. So the question down here is like, what can some abnormalities in these cells cause pathologically? So I don't know, if you don't know anything off the top of your head, if you want to kind of look for that in your book, it might not be a bad thing to kind of look up. And then people at home too, if you want to kind of throw some responses in the chat. I am following the chat as much as I can too. And you know, we were kind of talking about HIV earlier, so that might be one that comes up for you.
Didn't it like attack or attach to the T cells and increase or decrease? I can't remember if it was increased or decreased.
So it's more like the T helper cells. Yeah, and it's very complex. And I think there's a slide on HIV as well in here too. It kind of goes into that more in depth.
So can you increase the T cytotoxic if you put it on tumor?
I mean, tumors are complicated, right? Because it just kind of depends on the type of tumor, where it's isolated, where it's located, and then how the body's attacking it. Or, you know, because with tumors, a lot of times they'll even be benign, so they don't actually impact the body in a negative manner. A lot of the tumors that we have are benign. So the impact that it has on the T cells in our immune system is going to vary. So they're not all going to be cancerous, where they're impact on the immune system. Elizabeth, did you have a question? I'm sorry, I just saw your hand. Or did you have one?
No, I just, because you said that if we can comment what we read here, and I just was reading that, you know, some of the disease can be that these T cells can attack our host cells or the good cells, or activate your immune disease. I don't know if that's what you was asking, that if we can.
Yeah, that's definitely a component of it. Yeah, absolutely. And then kind of like going into one of the questions was about HIV and kind of how those T helper cells, so just HIV can suppress those T helper cells, and obviously helper is something that we want around in our body, so that's one of the impacts of that virus specifically. And then T cell function, the cytotoxicity by direct kill, delayed hypersensitivity, memory for secondary response. And you know, Tom, who did these slides, he's been teaching this for a long time. So there was obviously like a really big section on T cells. So I feel like while you're studying, probably studying T cells is going to be like a good place to focus your attention when it comes to the immune system. And this diagram will also be in the PowerPoint, and I think it does a really nice job of kind of talking about how the immune system works with T cells. It's not very large, so you can't see it that well, but when you pull up the PowerPoint, you'll be able to see it in a larger context. And in the videos as well, you know, I was kind of talking about with the genetics, they're going to go through like what happens in the movement of the T cells, so that way you can see them kind of infiltrate the cells and what happens in various illnesses, because we'll get into this a little bit later, but, you know, talking about tumors, like there's going to be a different response if it's a bacterial infection, a viral infection, a fungal infection, kind of having some understanding of that. It's going to be the rare patient that comes in and is like, how are my T cells impacted by this infection? So I don't think you need to go like that deep into it, but it's more like understanding the different infections that can occur. And then cytokines, you know, they're really like the hormones of the immune system and our communications network. So I'm sure that you guys have run into like interferon, especially in the hospital system, tumor necrosis factor. I mean, these are words that in the hospital system, I feel like we hear on any unit that you're working on. So just kind of having a basic understanding of cytokines. And then again, these are slides that I think are really valuable because you can write them out, right? So there's gonna be, when we go into hormones too, there are grids where you can start up at the top and then make your way down in order to better comprehend, like, where are the T cells and how do they impact the immune system? I know you can't see it, but you will be able to see it. So this would be one that would be a great one to get a piece of paper out, get your colored pencils out and kind of diagram down. And then any questions that where you're like, I don't really understand the depth of that you feel like you need to understand it better, to get your textbook out and study it a little bit more in depth. And this is, you know, again, going into like cellular immune response and a humoral immune response and how they differ. I think even this diagram is a little bit more in depth than you need to go, unless you really big immunity. So I want to spend a little bit of time with a group activity on the inflammatory response because I think it will help. And there are some answers on here for each one, like the mast cells and the leukotrienes, prostaglandins, platelet activating factor, and the cytokines. And I wish I could break them up into groups, everybody at home, but I can't yet. But I will have the power to do that hopefully by the next class. So you're still gonna have to work on your own. But I think what I'd like to do actually, I'm still gonna have you guys break up because I don't want you all to have to do all of them. So for the people that are, if you guys can do mast cells and kind of talk about that, and then if the three of you can do leukotrienes and kind of dig into these questions on that. And then I'm gonna have, I think there's only 9 participants right now. So Elizabeth, Andrea, Annette, and Danny, if you guys can work on prostaglandins. And then Carla, Kayla, Marlena, Nicole, and Susan, if you guys can work on cytokines. So just answering the questions, you know, what is it? How is it started? What does it do? And then what medications affect it and how? And I think, you know, the thing that's going to be the most relevant are that medication piece, because the more you understand medications from this context of pathophysiology, then the better it's going to be when you get into pharm. And then we'll take just until like 8:20, so about 7 minutes.
The old lives.
Oh, yeah.
She's talking about me and it's fine.
Like, I'm okay with that.
I'm gonna be 40 in a couple weeks and like just recently my eyes have been like, I can't
What's
really.
it called when you can't see up close?
I know it is called something I'm forgetting.
Presbyopia.
Okay. How do I know that one?
Say
what it's called again?
Oh, to be 40.
Say what it's called again?
Presbyopia, Presbyopia.
Is that better? Can you guys see it? I know it's hard.
It's just me, it's not your kids.
No, but it's fine. I mean,
I had 20/20 vision my whole life.
No, we'll make sure to send it out. I want everybody to have what they need.
I just sent Veronica, I sent the IT people, I just sent Veronica, who's the previous instructor, who has a Mac also, so I emailed her. But yeah, definitely by the.
Are you looking to two?
Yeah, well, actually not all right now, so this is one, yeah, the 3590 is 3590.
No, but
This is their final 6 months of preceptorship. I've got 18, 5. And then my mentorship, is this empty one? Is this empty one? Or this is one that I've got? Oh, this is one that I've got a student that took an extension and she. Except two.
What they do.
They're gonna have a leadership on.
It is not, oh, it says, what is this?
Okay, so you guys feel like, are you okay? So you're still. Feel like we think we're okay.
You can tell us, we don't right or wrong.
Okay, so we will kind of come back together. Are you guys ready to share with us what you learned about mast cells?
I can't find much of this part in the book about mast
Okay.
cells.
So that's good to know too, because if you, and that's the other thing for everybody at home too, if there are things that you're looking up that you're just like, I can't find resources, let me know. Again, these are not all things that are my thing, but I have lots of resources. I mean, of all the instructors that are at the University of Phoenix too. So if there's not enough in the textbook on mast cells specifically, let me know. And then we'll find videos and we'll find some additional information too.
I mean, you found it on a computer, but I found it in the book.
That's good though, that you found it on your computer, so being resourceful is the other part of being a great NP, you know?
It's so true.
Yeah.
Absolutely. So tell me with mast cells, what can you share with us?
It works with the IG, I mean, it's more the histamine allergic reaction, seems like that's what it focuses on, and
With IgE specifically.
so I mean, how medications kind of, that's kind of hard to find, but I don't think you'd wanna decrease your mast cells per se, and I guess some medications can actually lower your
Mast cell activation.
mast, and you're just not gonna have the reactions. Or it could be hidden reactions, and you could be having something that you don't know you're having to it, but then.
Yeah, can you guys think of anything where mast cell activation would be something that would be a nuisance in life or that you would want to control, or a medication that might?
Living in Arizona.
Yes. Yes, right? Yeah. So like, did you guys find any medications that can help if there's?
I heard you guys back here mention a med.
Probably any of those allergy meds, we said monoline cash.
Or common, or, I like Zyrtec.
Yeah. So cetirizine, loratadine, that's the other thing that I would say too, honestly, you guys will talk about this in pharm, I'm sure, but knowing generics, oh my gosh, because like the difference between Zyrtec and cetirizine is insanity. And the active ingredient in Zyrtec is the same, so it's like, what is the difference? Nothing, unless your patient tells you it's different, and then it's different. Okay, so if they tell you the name brand is different, it's different.
Go with it.
Go with it. Yeah, so yes, so when you're thinking mast cells, like think that, like allergies, diphenhydramine, Zyrtec, Claritin, those sorts of medications.
That's what I was like sitting.
They inhibit the production of mast cells, is that what they do?
Yeah,
Like
so when you have mast cell activation, all things with the immune response or in the inflammatory response aren't necessarily bad. However, when you're talking about like symptom activation and your patients are coming to you and they're saying like, I'm miserable, I need this to be better, then we have to treat them. And so one of those methods is to prescribe a medication or tell them to counter a medication that's gonna help to stabilize. It's not like completely depleting their mast cell activation, but it's like making it to where they can have a more, tolerable experience in daily living. And yes, in Arizona, I mean, allergies are very prevalent, so. Okay, how about leukotrienes? Is that what you guys said?
Yes. So it seems like leukotrienes, that's how you say it.
That's how I say it.
Yeah, are kind of where's the book, what did it say about the histamine response here? It said like they're kind of a slow reacting substance of anaphylaxis. And they're from lipids, like they're a lipid mediator from lipids, I think. And it's the same, it seems like there's a lot to do with people who have asthma, have a higher level of leukotriene. Those are like muscle contraction, increases mucus production.
So you think about like, that's like the cool part about patho, right, is that like, you can put all those pieces together.
Yeah.
Of like, okay, so that's what's happening, and you don't even have to go super, super deep, but just knowing that that's the activation and what also kind of distinguishes like allergies from asthma, right? Because there is some mast cell component for many types of asthma, but not with that same response to the leukotrienes. And that, mucoid production that is pretty standard for asthma.
Would the leukotrienes will be present in someone who just had allergy and not asthma? Is it more just like, because it is more of that bronchoconstrictor or that mucus production isn't more related with something like asthma than just more allergies together?
Yeah, but I mean, it's not so much like, these are all present, right? So it's not that they're present.
Just not present disease process.
Yeah, and what's the body's response to it, right? And then so then once you know that, then knowing which medications you would use in order to help dampen that response that the body is experiencing. Did you guys find an example of a medication that might be useful?
Yeah.
Okay, anybody take it, have a friend that takes it?
My daughter's on montelukast.
That's singular, right?
Yeah, so it's a very common prescription that you guys will write and practice. I mean, when you do your preceptorship, you will come across montelukast, and usually we all say singular because it's easier to say. So even though you need to know the generic, sometimes the generic is really hard to say, so you'll hear everybody use the name brand, and singular is one of
That's what I
those.
was looking at, chlorphenamine.
Chlorphenamine,
Yeah,
old antihistamine.
yeah, that's what they're diagnosing for my, it sounds weird, but they're diagnosing that for my cat. That was right, allergic rhinitis.
So then you can bring your pets in it too, right? Because there are a lot of medications that your pets are on that we use too, so.
I'm guessing Zafirlukast is probably like montelukast, probably the same type.
Probably the same class.
Yeah.
Yeah.
It's an older one.
Maybe
An older
Zy-
leukotriene blocker.
I don't know how to say that to you. But Zyflo is maybe like a nose spray, right? What is it, Zyflo? That's also a leukotriene, like
What's wrong?
Brooks working out.
Flonase, that's
Like
the, or is that a?
I'm not sure if Flonase is or not.
It's a steroid. Nasosteroid.
Yeah, that's a steroid.
Nasosteroid.
Yeah, but some nose sprays are steroid and I think some are
the
histamine, right?
the histamine response.
So like azalastin.
Is it
Astelin or
Yes.
antihistamine.
Same thing with Flonase. Flonase is gonna be like your best friend if you do family practice, because it actually works.
So what's the difference of like, would it be, like, if you wouldn't like go and see if there's leukotriene involved in or something, so like,
No, not at
would
all.
you just tell your patient like to try Zyrtec first, and then if it doesn't work, then you prescribe montelukast? Is that kind of how it works?
Yes.
That's like one of the.
A bit, but not always though, because you're gonna know, maybe not when you're initially in practice, but you're gonna know based on the patient history and how they describe their symptoms, if there's an asthmatic component to their allergies, right?
This could be like a better.
Yes. So especially kids, because a lot of times people start taking singular as children, because that's when they're diagnosed with more of like an asthmatic allergic reaction.
Leukotrienes
Yes.
versus the symptoms of.
And they may be on both, like sometimes patients are on both, where they're taking both the histamine with the mast cell for like a Zyrtec, and then also the singular. They may need both. I found in practice that once somebody started taking singular, they were good. Like it really, really, really helps to reduce symptoms. I don't know if you found that with your daughter, or if she takes both.
She's such a.
You're like, she takes all the
Just ate
medications.
her med list, she's 18. She's in the
So sometimes you have to take
She's
all of them,
on
and
all
you're
of
using
it.
Flonase and Zyrtec and singular, and maybe an inhaler. So that's the thing with singular too, that you have to be mindful of as well, because if it's an asthmatic situation, you wanna make sure that maybe the singular helps, but they also might need an albuterol inhaler, right? So like help if they have an acute reaction. So the patient history, which I think you guys will be getting into when you do physical assessment and everything, is the most important thing that you can do as a provider. You do it a lot as a nurse, but as a provider, it's even more essential, because without that patient history, It's like you said, what do you do? Like, is there some test
Yeah.
that like you check out, like what's their leukotriene level, what's their mast cell level? No, we talk to them and then like get a good case history. And if they're children, we bring their parents and the parents let us know what happens when they're triggered, what happens when they're around another trigger.
No, she has had hives for 8 months, so she's a type of diabetic, all these things, but she has been on double Cyzal and double Allegra for like 6 months, and they put her on one of the cast recently, and I'm just like, this poor girl cannot handle it. It's so sad. And no, like she was saying her friends, she's on Xolair, it's terrible. It's just terrible.
So she's not on Xolair?
She is.
Oh, she is. And it's still not working? Holy Jesus.
Just had a skin biopsy today from a derm, because she's seeing a rheumatologist, she's seeing
Double dose.
and she's in college, so she's
dry
like
and
away
dry.
from me. It's terrible. It's terrible. And as a mom, I just feel like a mom nurse,
And
helpful and helpless, you know?
you're gonna know a lot about that part of care.
I know, I do.
Yeah.
Unfortunately.
No, don't say unfortunately, because you know what, you'll be an expert probably in like asthma,
Type 1 diabetes.
immunology.
I've been for 7 years.
There you go. There you go.
And it will make you a really good provider for the patients that see you, because you're gonna understand it both, and that's true for everybody that's on here, like those life experiences of you both being a nurse and then as family members, like it's not always your kids, I mean, it can be loved ones, but those conditions that you've been really intimately involved with, you're gonna be able to talk to your patients both from a provider standpoint and then also as, and sometimes as being the patient of experiencing it.
You have a lot more empathy for people.
Yeah, I think my resource for diabetes was I am.
We all use each other.
Is there,
You guys understand
that's
that
my
about each
baby
other?
is diabetes, type 2.
You,
So
I don't
everybody
know
has their
anything
little-
about A1C, like I have,
Well,
everybody's like, I'm like.
and I don't read echoes, so.
There you go.
So the first group, I think you guys had prostaglandins. Does anyone want to, who's at home, who I put in that group, Danny?
Yeah.
You're awesome. What do you?
Yeah. So for the prostaglandins, what is it? I found that are natural chemicals in the body with like hormone-like qualities. Different tissues in the body can release prostaglandins, including the skin, the stomach, and the lungs. Some can cause inflammation, while other ones can suppress it. Prostaglandins only perform actions in the local area where the body produces them. They contract or dilate blood vessels or airways. They form blood clots or can also like break them. Too much of that can cause like arthritis, heavy menstrual bleeding, or too low of those can cause like stomach ulcers, glaucoma, congenital heart disease in newborns. And the medications that I found are the NSAIDs.
That's awesome. Thank you, Danny. Yeah, and so, go ahead. What else?
No, I said thank you.
Okay, awesome. Anyone else from that group have anything to add? It's okay.
They also mentioned that they are lipids and that derive from lipids autocord derived from the acid chain. I don't know how to say that word, but it's arachidonic acid. And they sustain the body in hemostasis function. And they also function as a pathogenic mechanism.
Arachidonic acid that you were, is that the word, arachidonic acid?
Yeah. They both sustain the hemostatic function and mediated in pathogenic mechanism, including inflammatory response. And like you said, aspirin is one that helps.
Yes. And Elizabeth?
Yeah, I just want to say something about the medications that I read, and it says that some of the medications that are synthetic prostaglandin are travoprost, and it's for ocular hypertension. And they use it also another kind of medication, synthetic, to dilate the cervix. When the person wants to have a baby, it's like a kickstart for labor. And then it's also treat pulmonary hypertension and postpartum hemorrhage. This is one of the uses of medications of these synthetic prostaglandins.
Yes, thank you. So, prostaglandins, I mean, you're gonna come across, with the COX-2 inhibitors and the ibuprofens and the aspirins, if you work in women's health, Cytotec is a medication that's commonly used. Some providers use it for IUD insertions, labor. So you guys will come across medications that are, related to prostaglandin. No matter what you do, doesn't matter what field you're in. You heard like cardiac, women's health, you name it, prostaglandins are a component of that. And just hormonally, in the work that I do with women's health, one of the methods that we help to control bleeding when a woman has like the Nexplanon, which is the arm birth control, is to actually do high dose ibuprofen for 5 days. And it's because of its impact on prostaglandin, and it can then kind of stimulate the rest of the hormonal pathway to stop the bleeding. So it's like little tricks like that, where if you understand a bit about prostaglandins, then you can kind of be like, oh, okay, this is how it works. And again, the rare patient is going to be like, so tell me the way of like how this ibuprofen is helping my bleeding. So just understanding like the basic information that's on this slide is going to be fun. I don't think that I assigned anyone the platelet activating factor, but it kind of causes that blood clotting, blocking antigen from entering the blood. And then one of the medications would be, which is listed here, is the raputidine to treat like allergic rhinitis. And then the last group, can anyone kind of talk about cytokines? Because that's obviously another big one.
So I'll go. I have the cytokinins are proteins. They're like peptides that cannot cross the lipid bilayer. It consists of large family or small molecular weight. Its main thing is to promote growth and activity in the immune system, cells, and blood cells. What does it do? Is that? And then I found just a few medications, but just by glancing, but not really going in depth. It was like azithromycin, something like that. It's a drug that blocks cytokinase. And also I found interesting was magnesium and vitamin D supplements.
Yeah, that have an impact on the cytokine system. Yeah.
Thoughts? That's it, Susan.
Methotrexate.
And then, so I think with cytokines too, it's also just kind of like not necessarily knowing the medications themselves, because a lot of them are like the crazy long named medications that you're not going to come into contact with unless you're working in those type of like hepatitis B, hepatitis C, like unless you're working in hepatology or like you're more treating those types of patients, you may not come across those. Like methotrexate, you'll probably come across that if you work in family. I prescribed a lot of methotrexate because if you live, depending on where you live, sometimes you have to do everything. So I was the rheumatologist, the endocrinologist, the allergist, the dermatologist, because if you live in a smaller setting, if you stay in Phoenix, fine. But I know living in other countries too, there may not be specialists on every corner where you just kind of have to learn things. And a lot of patients are on methotrexate now because they have so many rheumatological conditions. So yeah, that's fabulous. Thank you, everybody. Get back to the slides. And then kind of moving into infectious disease, that immune response, immunity, inflammation, it kind of involves everything. Those are the objectives. I'm not really gonna read them out. Those will be on your PowerPoint slides if you get them. This is like a big slide. Again, just kind of doing an overview of the immune system and our response to invaders. So this would be another one, like maybe get the pen and paper and colored pencils and just kind of take it out, start from the beginning. To understand immunity to this depth is going to be really hard. So use your time wisely. Like you can stay a little surface level because you're learning so much, but make sure you have a basic understanding of the things that we're gonna go into next. And then this chain of transmission from the host to the victim. Waiting for it to pour. This is like so laggy on my end. So you've got, as an example, the reservoir, then it goes to the portal of entry, and COVID is a great example of this. You know, when it first came here, we weren't exactly sure how was it entering the body, so we wore like hazmat suits, right? I don't know what your guys' experience was in the hospital, but when it first came, it was like full-on hazmat suits. And then now we wear nothing, or maybe this little mask that doesn't do much, and it's still here, right? So, and then mode of transmission, how is it coming in? So obviously like insect bites, and we'll talk about different infectious diseases that are related to that, nasal drops, droplets, semen, obviously with sexually transmitted infections, the portal of entry, how is it getting in? And then how susceptible is the victim, right? Because again, COVID's a great example of like, you had a family, one of the people may have had a comorbid condition that caused them to be in the ICU or maybe even pass. And then you had another family member that might have had the sniffles. So susceptibility is a big factor in infectious disease of all types. So stages of disease. So you've got like the incubation, what's the period from initial exposure to the first symptoms. Prodromal, initial symptoms occur but are usually mild. Invasion, how are the tissues affected, and then the immune and inflammatory response are triggered, which we've already gone through the immune system, so then we can have a better idea of like which cells, how are T cells helping or hurting, what's going on in that aspect. And then convalescence, the immune and inflammatory response have overcome the invader. And then the symptoms begin to decline, possible disease is not gone for good, and then they can go into latency stage. I'll keep bringing COVID up because now we have long haul, right? We didn't have that. Like when it first came out, I didn't have patients coming in with long haul. We had no idea what the heck that was. We had patients coming in with these crazy symptoms that we didn't understand, and we didn't link it necessarily back to COVID until we had studied it more and had more information. Factors of disease, you've got the virulence, so the capacity of the pathogen to cause disease. So like measles has low virulence, rabies has high, communicability, how is it even transmitted? Do we know that? We kind of have to know that in order to get an infectious disease under control. I will say that infectious disease, if this is something that you're passionate or interested in, is obviously a really growing field right now because we have a lot of humans in the world, and so we have a lot of infections that we don't understand and we don't know about. So understanding that's a pretty big deal. And then also, what's the environment like? Like, is there contaminated food or water? I don't know, like, even from a show perspective, there's all these shows out there. So the one that I'm watching right now is like The Rest of Us, The Lost of Us, can't remember. Last of Us. Fascinating, right? Like, it's like a fungal infection that causes like mass destruction. It's in the food. Everybody ate, but it was in like, you had to eat it over time. That's why it was everywhere. So things like that are pretty fascinating. And then, food, like insects. Like if you go to other countries, then you have to have protection from things like malaria, right? Because if there are bodies of water, like standing water, then you're going to be more susceptible, and the organisms are going to have an easier time. Bacteria. So this is like a pretty lengthy slide, so this is kind of like death by PowerPoint on this slide. But kind of talking about different types of bacteria that you might see. Mycoplasma is pretty fascinating because it's something that can be found in, pulmonary conditions, but then also actually like vaginal conditions. So I would diagnose mycoplasma in women too. So you may find some of these organisms bizarrely if you specialize in things. So you're like, I didn't even know that was a thing. So not that you have to know that,
How do you
but
find that by like a culture?
a culture. Yeah. So you do like a vaginal culture. So women can be, so patients can be really symptomatic and you have no idea what is going on with them. And so sometimes that's where you send them to infectious disease, because if you can't figure it out with standard testing, and I've sent patients to infectious disease as in sexual medicine, because it was like we couldn't figure out where the heck the infection was coming from, and nothing that we did to treat it could treat it. Yeah, it was working. So, one that you'll definitely run into. Some of these are more are less likely. Obviously, TB is something that we've all been screened for, that you'll test for, and then chlamydia. It's like everywhere. And with sexually transmitted infections, one of the main issues right now is that the guidelines are changing because those organisms are no longer susceptible to the antibiotics. So the CDC actually just recently in 2022 came out with new guidelines for treatment because the standard treatment, patients were becoming resistant. So that's scary. It's not what we want. So that's why we don't overprescribe antibiotics, right?
So what is the new treatment, just a different antibiotic?
Different
than what it
antibiotic.
used to be?
Yeah. So sometimes it's a different antibiotic, and then sometimes it's the same antibiotic for more courses during the day or a longer period of time. And then with chlamydia, I'm trying because I haven't treated anybody for a while. So this is such a No, it hasn't been Rocephin for a long time because that's an injection. Yeah.
It's been a long time.
Rocephin, it's like, we try to stay away from injections. Although, like sometimes I like injections because they kind of hurt. So you're kind of like reminding people like, you got them because then you don't have to have those for you.
So what do you use for your research database then? Talking about how these guidelines change?
Yeah, so
What do you use to keep up
So
on that?
CDC, like hands down. So if you guys are interested in that, I can I messaged the link that was shared earlier, and then I can message you the link to the CDC. But literally, if you just Google search CDC, if you just Google search CDC and STD treatment, it comes up. It's available to anybody. Like, it is not just something that's available to providers. It will literally come up with like chlamydia. It will do patient information. It's a great place to find information for your patients. You can print out a one-page handout. It'll tell them how they're being treated, how this is transmitted. It will give you all the information that you need to know so the patient walks out with it. Because they're not going to remember, patients don't remember anything you tell them. Ever. Like, you have to write everything down. Like, they just don't. And we don't, right? I go into a room and I just become, I don't know what happens. And then you leave and you're like, I don't know what just happened, but they gave me something. Through the pharmacy.
It's a CDC app even, isn't there? There's an app for everything, you guys.
Yeah, I think
They're using doxycycline and azithromycin, which is like or levo.
So like, these are some of the ones that I have, like the CDC STI treatment, ASCCP, which I'll get into some of these when we get into women's health. I mean, there's even an app that's just yeast. So we're gonna, literally, it's just on yeast because yeast is such a hard thing to treat. So that is so great because like, use your apps when you're in practice. You don't necessarily have to bring your phone with you, but have it available because there's too much to remember. But don't be overwhelmed because there's an app or like a website or something. You can always find the answer. And then, so bacteria classified as either gram-negative or gram-positive. Gram-negative has a lipid coating in the outer membrane or an endotoxin and does not take up stain. And then the gram-positive does take up stain. Let me see. I actually really liked this video, so let me share this video with everybody. And this was one that was okay to share. Oh, it doesn't have any sound.
It does, you have to press, go back.
Do I have to go to my sound?
Oh, there you go.
It's really feedbacky though, so that's not right.
It's actually, if you back it up, before you share your screen, there's one that says the audio down here, so go back one more screen.
Well, that's a totally different. You can hear. Here, I can stop sharing. Sorry, guys.
So share application screen again. Yeah, and then there should be something right there about website. So this map is so different because they're
But it's not, it's the same computer. You're like, it's because it's a Mac. Okay, well, maybe we can't do that, but I would love it if you guys watched that video. It's small, or it's short, it doesn't take very much time. I think it's like 3 minutes, so it's not very long, but I don't want to share it.
When I do mine, see it says share audio system. So when I do, yeah.
They gave you the power, I have no power.
Yours is made in a different country.
It's made in a different country.
Every single one of us.
It's definitely made in a different country.
She's the only one that doesn't have a Mac. We're outnumbered here.
You guys all have Macs?
Yes. Yeah, you guys are in here, but everyone
All
has a
6
Mac.
of them. I'm old-fashioned.
For you. Everyone has a Mac in here. So it's this video is all on the difference between gram-positive and gram-negative. It's 3 minutes and it has 2.6 million views. It's a good video. So once you get the PowerPoint, and I think everybody at home actually has it, I would just click on it and just spend 3 minutes watching it. I'm trying to think. Let's see, it's almost 9.
Ooh. Was that you or me?
That was you. You infiltrated, you stole my.
Bad. I'm gonna get out of there. Okay. Smack me.
So there's a few activities, so I'm just kind of thinking which activity we want to do because there's a bit more content to go over. So we've got one that's on hypersensitivity reaction, one that's on infection, and then one that's a bacteria case study. I feel like let's start with the infection one because I have some slides and stuff on the different types, and I think that's what you'll run into most in practice. I mean, hypersensitivity, you'll run into it, but it'll just be a little less, especially in like your family practice rotation and stuff. So let's go ahead and do the infection one, and then we'll kind of break it up in here. Again, if you guys can stay with your same groups, that's great. At home, Andrea, Annette, Ashley, Danny, and Elizabeth, if you guys can do bacteria. And then Carla, Kayla, Marlena, Nicole, and Susan, if you guys can do virus. And then if you guys want to do fungal infections, fungus, and then parasites for this table. And then so I'll make this big again. And then you'll just answer these questions that are at the bottom. And does anyone at home have any questions? If you do, you can either put it in the chat or. And we'll work on that until about 9:05 for the people at home.
The body does not recognize them as parasites. That's what's saying. I'm feeling so itchy here. I can't even.
I'm just curious, would it be serum B?
These questions, like, so most of these medications you might not see, like, chemical medications, general medications, so sometimes it's board questions. Like, when I used to make boards, I would go, sniff the what is brand new practitioner going to need to know in practice? Sometimes they'll trick you. So did you Google search like?
I just happened to I just wanted to know like how it would affect, and it just brought up study.com and I was like.
Well, and then it depends, like, is it working? So is study.com what you guys are using for boards?
No, I just happened, it just popped up and I was like, oh.
No, I have no idea. What I know is that chemical is the only one of these four that is the same practice. Yeah, I mean, you might see some of the other ones depending on how they work. Disturbed season like antifungal. Like I know some medications that are more for vaginitis because that's what I did.
Which was like the
nitropamazole, so a lot of the azoles.
Of the good note is that
and like boric acid, which isn't antifungal, but actually helps to treat antifungal and bacterial. So but stuff like that, if you're gonna study, I would actually really say that board questions.
Okay.
Yeah, and then always go for.
We were looking at APA.
Well, have they given you guys a site to kind of like start studying for board questions?
The Cohen review.
What is it called?
The teacher in the last class, she was telling us APA.com.
Oh, yeah.
But on the YouTube, there was Cohen review.
Okay, yeah, so I did Fitzgerald when I studied. I liked Fitzgerald's. I don't know that she meant it. Find a site where you have board questions and like, I personally, in the program that I did, we started doing board questions in Patho. Because the more board questions you can do, the better. But in general, like you'll want to go with the common answers because again, they're testing you just like as an RN. Like boards tested us for like, you're not a seasoned cardiology nurse. Like you're a brand new, just starting out RN. So kind of always go with the answer to the question that you have some familiarity with. It's probably right. Chances are they're not going to put some obscure medication that you never ran into in any of your learnings. So, okay. So, the group that did bacteria, is someone willing to talk to us?
I will.
Okay, Ashley.
Yeah. So a bacteria is a single cell microorganism. So basically it lacks organelles and an organized nucleus, but it causes bacterial infections. So it gets into the body through like open cuts in the skin. You can inhale, like if somebody's sick and coughs and you have a bacterial infection, it can spread that way as well through like any opening in the body. Your body responds to fighting it through your immune system. So, basically, your body produces antibodies which help fight the bacteria, and so like your inflammatory response, which is kind of what we went over earlier. Pretty much, I think it was. What did I find? So it releases the chemicals, which is like the histamine, prostaglandins that help to fight it off. So that's when like you get infected and like say you got like a staph infection or cellulitis, you swell because that's the inflammatory response reacting to the bacteria. And then what else can be used to fight this? So like antibiotics, there's a lot of different types of antibiotics, broad spectrum, more specific ones, some that are resistant to different bacterias. So 2 examples of some common types. So like I mentioned like a staph infection. Staph is, on our skin. It's just like a common, what's the word I'm looking for? I just blanked. Normal flora. So it's kind of always there. But if you get a cut and that bacteria moves into that open cut, it creates an infection, commonly like cellulitis. So that's typically treated with like a broad spectrum antibiotic like Bactrim or Keflex, depending on the person. And then like another common infection would be like bacterial pneumonia, which is commonly treated with azithromycin or Z-Pak.
Awesome.
Yeah.
Thank you. It's great. Anyone else from that group? Just want to give everybody an opportunity, and it's fine.
So it's also mentioned that all bacterial is bad for you. So some of them are not harmful. So although that we know there's a lot of others that are harmful to us, but there's also one that's not, harmful to us.
That is such a great point. Yeah, that was something that I was going to bring up too, right? Like we actually have to have healthy bacteria in our bodies, and our bodies are made up of a lot of bacteria that we have to have. So that's one of the reasons why an antibiotic causes so many side effects, right? Because it doesn't always, it doesn't.
It's like a probiotic, right, to replace like the bacteria that the antibiotic eliminates.
Mm-hmm. Yep.
And I think they say most of the stuff now, but something that I read that the most harmful way to get bacteria in the body is in the bloodstream, and is when we see the sepsis infections. And some infections can be mild, but usually when it gets in the bloodstream is when sepsis happen, and it can be very bad.
Mm-hmm. And so what's an example of patients that we tend to see that in? Potentially, yeah. Yes, that's what I was thinking, right? Yeah, that's where my mind went, because you'll see that both in men and women and in the geriatric population a lot, right? If a UTI goes undetected, it moves into the bloodstream pretty quickly as we get older. Well, and they get septic. Yeah. So something to like be so mindful of. If you have a woman that comes in and you're in practice and she says she's a little dizzy, you do a urine. I mean, like any sort of neurological symptoms, think UTI automatically, and you will be protecting your patient by that degree to know that. Okay, so virus, I think, can't remember where it started, but I think it was Carla, Kayla, Nicole, and Susan.
So basically what I found is virus is a tiny type of germ to talk about it. So it can get into our body through nose, mouth, inhalation, and through tear ducts. So the action of it is like the B cells creates the antibodies, and it alerts the T lymphocytes to kill the pathogens. And it is treated with antiviral medication, and basically no antibiotics is required. It's not treated with that. And treating is usually symptomatic, like Tylenol, Motrin, Advil, plenty of fluids, rest, sleep. And in severe cases, they can give antiviral like Tamiflu, and in HIV, influenza, HIV, we treat them with the viral medications, antiviral medications, and influenza and flu, we give Tamiflu.
That's great. Thank you, Susan. Carla?
Yeah, I also was reading that there's only like one, there's sorry, when I in my nursing, they've only like used like certain antiviral medication to treat viruses. Obviously, is not there's not treated with antibiotics like it is with bacteria. Most of like the common viruses are out right now are like the famous COVID-19, Hep B, Hep C, and HIV. And it's kind of like viruses. It's something you need to kind of just let it do its process, kind of like Bell's palsy. Was it Bell's palsy? I think it is. It's something that you just not need to like let it right out sometimes and just get a steroid and antiviral. And let's see, some of the, I was gonna tell you, there's like home remedies that you can probably try to like work with viruses, which can be, these are the symptoms. Sorry, I'm like all over the place. Of some viruses, which can be like headaches, respiratory distress. Sometimes it might cause fever. A lot of times just rest it out, and if you have a headache, take a Tylenol, but there's not like a specific med that cures all, viruses or something like that.
Yes. Yeah, so that's the hard part of being in practice too, right, is distinguishing. So a lot of times when somebody comes in with like pink eye, that's almost always a virus. It's either usually allergic or viral, but all the patients want the antibiotics, right? So they're like, my eye is red, like, give me an antibiotic. But we're trying to not create this antibiotic resistance. So colds, everybody wants a Z-Pack, and it's our job as providers to inform patients that most colds are viral. It's rare that it's bacterial. When it's bacterial, usually that's like after about 10 days of symptoms, which no one wants to wait 10 days for symptoms, right? Because we have work, we have family, we have commitments, we have responsibilities. So it's really hard to navigate that as a provider because you want your patients to like you, but you also want to do what's right for making sure that we don't contribute to antibiotic resistance. And the knowledge of knowing that the majority of these like acute infections are viral and they will go away. Like the best that we can do is what is exactly what Carla and Susan were talking about, and that's supportive care. That and having the healthiest immune system you can, right? So taking really good care of yourself. Okay, so fungal.
We found out it's called mycosis. It's usually more superficial, usually on the outside of the skin, usually toenails, sometimes ringworm, candas in the mouth. Immunosuppressive people are more prone to fungal infections and they can be more severe. There's not a whole lot, but we were looking at the medications, and very seldom they're very seldom systemic fungals, but your systemic fungal would be your like valley fever. And that can show up pretty much anywhere. But usually they're more topical. The medications, azole, fluconazole, Lamisil, Spornex, Norazil. Those are all the kind of medications that they use, Zifalcan, Nystatin.
So we have a pretty good protective system, but I would say that the main thing to consider in practice is that if you have somebody that's coming in with recurrent fungal infections, like what would that make you think? Like where would your brain go if you have this patient that like always has fungal infections?
Hygiene?
Something. What'd you say?
Hygiene or like the environment?
Yeah, so hygiene is is definitely something to consider. And then also what's going on with their immune system? Like we need to dig deeper as clinicians, right?
Immunological disorder?
Potentially, yeah. So some and you'll see that in all practice, right? So you'll find that toenail infections are very prevalent in your patients with uncontrolled diabetes. So when a patient comes in with toe infections, they're diabetic, you gotta dig deeper. Like, what are their sugars been reading? What's their A1C? Potentially, maybe there's even a rheumatological condition that's causing, like if they have recurrent vaginitis and it's like repeatedly fungal, what the heck is happening? Like there's something happening to the whole system of the immune response if you're having, because fungal tends to not be as disruptive to a person's life. You can live your life and have a fungal infection in your toe, right? Have onychomycosis on your foot and live your life. It's harder if you are hacking up a lung and sneezing all over the people that you work with. You can't really go to work that way. So people will like live with fungal infections that are pretty uncomfortable because they can't go out into the world. So it's our job as clinicians to kind of dig a little bit deeper rather than just treating and being like, okay, well, you're going to take this medication for 8 weeks, see you later. Like dig deeper. Because maybe they're an undiagnosed patient with diabetes and you're the one that's going to diagnose them because you're going to think a little bit past that, because you're going to know the pathophys and you're going to know that fungal infections are more likely in susceptible patients. And you're going to check on their environment, right? Like what is going on in their home environment too. So yes, that's great. Okay, parasitic. Are gross. I agree.
So they're organisms that need a host. They need in humans, the body to get food and survive.
They come through like openings, like sores in your skin, or they can come through your GI tract. They can come vaginally. I guess anywhere that there's probably an opening. Yeah, but through food. And
you said IgE response.
yeah, the way that the body responds is that it's like an IgE response is what we read about. But it's really interesting, your body almost masks it, so it like doesn't recognize it as a bad.
Parasites are very smart.
Super
They
subtle
turn off like the signaling systems. They hide themselves inside cells or make themselves look like our own cells so that they're not attacked. So that's kind of scary. Because sometimes the only way you'll figure it out that you have some kind of parasite are the symptoms that cause this. Like if you have tapeworm, you'll notice because you're eating but you're malnourished or you look malnourished. So that at that point you have to help your body by taking medications to get rid of those.
Like anti-parasitic drugs, antifungal agent, anti-malarial drugs. So malaria is from a parasite. It's brought in by a mosquito, the host person. And yeah, we were saying that like right now the big thing is that people are talking about like all over TikTok are like these parasite cleanses that are like really unsure about the validity of them. Like, it seems like one of those TikTok trends, you know what I mean? Like, we were Googling stuff about that.
So Doxy, would you want on the methylplan? Would those be the medications?
For doxycycline?
To prevent like
No,
malaria.
that's
and
an
stuff like that.
antibiotic.
Yeah. So I think in malaria, I don't remember the treatment protocol for malaria, but sometimes they will use antibiotics, but it's kind of like almost symptom secondary rather than to treat the.
I was on methylplan when I was deployed.
Yeah.
And some people that weren't on methylplan
were then treated with doxy.
Treated with
When they were
Doxy,
there.
and we had to take it every Monday, or they had to take Doxy every day.
That was for prevention though.
Okay, so that's prevention.
I think they use like a combination of
Yeah, I was
drugs.
gonna say, I've never seen someone just, because I've traveled extensively, and I've never seen anybody take doxy for malarial prevention. I'd have to look that up. I've never seen an antibiotic used for prevention of like a malarial disease. So I'll have to look it up.
Okay, because some people couldn't take it, and that medication is weird.
Oh yeah, it'll mess you up.
Vivid dreams, and this is crazy. And you call it malaria Mondays, because we don't have to take our pills.
Yeah, it's horrible. I agree with you. I had the same response. It's horrible. Like I'd rather not take it and like use the DEET or whatever. So there's a question about, can you explain a bit why do some people tend to get sick with an upper respiratory issue after an intense workout? What happens in the body that leads to that? So, a lot of that's gonna deal with like cytokine response, the inflammatory system, cardiovascularly. I mean, that's like a complex question. And in terms of an upper respiratory issue, then it makes me think like, are they asthmatic? Are they having some sort of like asthmatic response? And then
Exercise.
exercise-induced asthma.
Do you also think genetics can be involved in some of that?
Potentially.
I don't know.
Yeah.
It feels like it sometimes.
I mean, definitely potentially, but I also think that there's a lot of like overworking our body. And so anytime it comes to exercise and movement, I always counsel patients to start really slow, because I think when patients go out and they're like, I'm just gonna do a really hard workout even though I haven't exercised, there's a lot that goes into your body's compensation, because we have to use compensatory mechanisms for managing that excess energy output. So all of those things, Andrea, I think are involved. I guess I'd have to know exactly, again, as a clinician, the first thing you want to address is asthma, right? If that's what it is. And so if it is asthma, then you can prescribe an albuterol inhaler. They can take a couple puffs before they exercise, before activity, and that usually kind of keeps things open and pulls them over. And then I would also counsel any patient that came in with that response, again, to start back, like go back like 5 steps in the intensity of your workout.
Could it be some of the supplements I take, like the ATPs and the ACCAs?
Potentially. I mean, I would say that like people that don't do a lot of working out tend to not be in that world yet. Like most people that don't work out don't know about blockchain amino acids. Like BCAAs, I think, are like kind of that next level. But yeah, if you have patients that work out a lot, then you have to like also monitor their protein intake, because then their protein intake can impact kidney function. So sometimes you'll see those like really active bodybuilder types with really reduced kidney function. So then you have to like know, okay, I know the kidneys, and we'll do a lecture on renal disease and the renal system. We have to know how important our kidneys are in processing protein, in order to know, hey, you might want to back away from the protein supplements. And just the supplements in general have a lot of other junk in them.
Something interesting culturally was Sue was saying that in Korea, everyone takes like an annual antiparasitic, like the doctors prescribe like a pill that you take annually, and that's very common, like it's just interesting.
And so we
don't do that here.
Because we don't have the same parasites.
Like the living is that,
Parasitic infections in the United States are rather rare, other than, like trichomonas, like vaginitis, not so rare and totally disgusting. Like when women come in with a discharge that you're like, what happened here? It's probably trick. Once you see trick once, it's everything. It's everything, and you will not forget it. And then when a patient comes in and they have trick, I mean, you're gonna have a pretty good idea that that's what it is.
What is that?
Just parasitic semen, just like body to body, men's parasitic men.
And no offense to our men.
Sorry. You have to report these to the county.
Yes, and then you have to report it to the county in order to. And actually, most of your EHR systems have their own system, so it's not like you individually have to call. It's flagged in the system, and that goes over to
when
counties.
You chart it or something.
Yeah. So as soon as you do your ICD-10, it flags it over to them. Okay, so there is another case study. So I would encourage you guys, there's 2 case studies on hypersensitivity reaction to bacteria. So I would encourage you to, as you're studying, maybe go through those case studies, because again, the instructor that wrote these slides knows the test really well. So those are things to definitely focus on, and maybe go through the studies on your own. So this is, more nitty gritty in terms of gram stains and the different types of gram stains. And we talked a little bit about some of them, like staph, streptococcus. Again, I don't know that you have to go really deep into this piece of it, just a basic knowledge. I don't even know that you would need to differentiate. Like, these things are not going to be on boards. These are not things that you're going to be differentiating in practice. Again, just have like a basic knowledge. And then mycobacteria, relevant again because of TB, which you will see in practice. And then leprosy, which, I sure hope that's not going to be on your boards. That is not going to be something that you guys dealing with in practice, at least I hope not. Yeah. So potentially, I guess, if you, depending on the patient population, but.
Not here, I don't think it's just.
And then tissue damage and disease, exotoxins, proteins released from bacteria, and then they're destroyed with extreme heat. And then endotoxins released from the cell wall of bacteria upon lysis of bacteria. So, like E. coli and Klebsiella, you're gonna see those organisms, like they're gonna be on your urine cultures, you're gonna see those names in practice. So having some more familiarity with them is important. And then you have the invasive factors, penetration through natural barriers, can attach via the pili on surfaces. So that's again what we were talking about, like how are they transmitted into the body. And then they can end up in the blood supply, which we were talking about earlier, and then patients can become septic. So we want to get them treated before they become septic, right? And then, so polysaccharide coatings that form capsules, and they prevent phagocytosis, like staph, bacterial superantigens produce an inflammatory response separate from normal antigens, necrotizing fasciitis, which you actually will see in practice, like particularly if you work with diabetic patient population. It's horrible. It's really horrible. So again, like that's where I think that nurse practitioners can be really, really important in the clinical care team, because we were just downstairs in Eric's lecture, and one of the things that she was talking about is like with patient care, it's not about telling people what to do, it's about figuring out what is their life like and how can we help them to navigate the world of diabetic management in their life. It's not like, well, use your insulin. That's like the stupidest advice I've ever heard. Like, I mean, like, as if people don't know to use their insulin. Like, so it's about like, what are the barriers? Like, what's keeping you from using that medication? Because you can understand, I mean, and you need to understand some of these the pathophys, but you also need to understand how to communicate to your patients what's happening in their body in a way that they can understand it. So you kind of have to speak like provider language and patient language, and you have to know them both. And then these are just some diagrams in terms of, a body part, what is happening, what are the common bacterial pathogens. If you work in women's health, really if you work with any humans, you're gonna see E. coli in the urine, right? That's gonna be the cause of the majority of urinary tract infections. You'll also see a lot of pneumonia, so knowing the strains that are most common for pneumonia, and so on and so forth. So those are kind of some nice tables just for additional information. And then also kind of like, this is the start of some farm that's in here in terms of the name brand and the generic brand of antibiotics. We talked a little bit about fungal infections. I'm pretty fascinated by fungal infections because they really do impact women's health. And then also I did a lot of management of diabetes for many years. So I think that there's so much we could do in prevention around, like, again, protecting our immune system so we don't develop them. So little information on here, they tend to be bigger when compared to other organisms, and they're generally classified as yeast or molds. They are part of the normal flora, so Candida can be present. So it's kind of similar to like bacterial infections where you want to have some bacteria, but if you were to like, let's say, randomly diagnose, there are certain candidal species that like people are asymptomatic, but they don't have any symptoms. So then you kind of need to decide as a provider, what are their underlying susceptibilities? Like if they're, compromised, you always treat, right? Like always. And then, so there's also, I don't think we have time to do it because we have some more slides to get through, but there's also a fungus case study just on fungus, because then you can break down what we talked about with fungus even further. So Tinea capitis is going to be the one that you'll see with the babies. If you've had a baby, they probably had it. And then if you've done anything with newborns. And then onychomycosis. So it's like my favorite word because I remember when I first started diagnosing diabetic patients with toenail fungus, I was like, could not say that word. Like I could not say that word. So I went home one night and like just practiced it over and over and over and over again. It's like it's like the coolest word for it's so much cooler than toenail infection, right? So so sometimes you can learn like the medical term and I don't know, it's just kind of fun. So you can kind of go through that case study. And then I hope my computer doesn't die. It's like close to dying. Hopefully it'll last us 10 minutes. And then if mine dies, can I switch over to yours?
Do you have a record?
No.
Oh, sure you can.
Okay, I don't think I need to yet,
Yeah.
but I might have to. I'll bring it next week, for sure. And then parasitic infections, which we kind of talked about. I kind of agree. I find them to be like the most disgusting and scary. And anyone who's had, like I've had multiple parasitic infections myself and they're super gross. Like
You have.
oh yeah, because I've traveled a lot and
How long have you been?
well where I got the worst parasitic infection I ever had was in India and I was so sick and I was just like well enough to survive and my mom was kind of like you've lost like 15 pounds like what is wrong with you and I went in and it was like a super easy stool test like they found it right away I got on antiparasitic medication I was like healed like within a week like completely
Somebody notices something and like,
yeah
But she does missions. She does a lot of missions.
I do.
Tell them where you just
mission work I'm safer like I don't eat all the food but we have and those
Is it like for with yoga? Do you do stuff like that or
no so we do cleft lip cleft palate repair so I just got back from the Philippines in January so it's awesome it's great work if you guys can get involved in missions I don't know if anybody on
I would
at home has been involved but if you can get involved in missions I mean so when I go I actually work as a floor nurse so I don't like my role is not as a nurse practitioner because I started doing the missions when I was an RN and it's just amazing because you're transforming these kids' lives and the families just like they just hand us their children and they don't speak our language and they don't know us. They like literally just met us and they hand their kids over to us and then they come up with something and sometimes the kids don't have the pathway of being as like the course of post-op isn't as smooth as we'd like and the families still are just so beautiful. It's very different from the United States. It's kind of like a good thing to do to like be reinvigorated in healthcare. Because so much of the United States is like, when are you gonna help me? What are you gonna do for me? Where is my stuff? Like, give it to me now. You're too slow. And then when you go and do mission work, it's not that at all. Like the families are so gracious and so kind. And
how long do you go for?
Usually it ends up being about 12 to 14 days because it takes forever to get there. I don't know if you go home.
Yeah, like it takes like a day and a half travel, right?
Like you're like, I'm never going to. I'm just gonna live on this plane. Like move in onto this seat. So yeah, but mission
What
work.
countries have you been to besides?
Well, I was Peace Corps volunteer, so I was in Ecuador and did a lot of medical missions there, and then Philippines a couple times, and then Myanmar. We were in Myanmar, which was a
You were Myanmar, as you guys.
so interesting.
What's it called?
What was it? Burma. It's like old Burma.
Old Burma.
Yeah.
About
we
here,
have,
right?
yeah, and we have other people from like our Saudi Arabia and who was that in our group? I wrote it down. Yeah, Susan. Because Susan has practiced in Saudi Arabia and India. She might not be tuned in right now. But
Susan, are you there?
Is there a certain group that you go with? Have you always gone with the same group?
yeah, so I went with when I was in Ecuador, it was a different group because that was many years ago, but it was all cleft palate. And then the group that I've been going with is called Faces of Tomorrow. And you can look them up. They're always, if you ever want to donate to something, they're like great organization. But so doing cleft lip, cleft palate is a really, really big need across the globe. So if you're interested in that type of work, you don't have to do it. I literally do social medicine right now. But you get involved with the mission, you start with the team, and if you are good and compassionate and loving and work hard and you get along with the crew, then you can keep doing that work forever. It's great.
There are like lots of qualifications.
No.
Really?
it's really just like meeting somebody, knowing someone, and then like working hard when you're there. I mean, every once in a while somebody will gas back because it's just obvious it's not a good fit. Because it's hard. I mean, you're working like 14 to 16-hour days, but you're an RN. We've done that. So that's anything. Yeah. So, but yeah, I can't say enough about if you feel like you're just done with healthcare in the United States, go on a mission, and then you can come back and keep doing the demands of all of your patients. So I would do the parasitic case study, and then kind of going into viruses a little bit. The smallest in size of the infective agents. And sorry, I gotta get back in here. Oh, we had a question.
She said, do you pay your way?
Oh, do you pay your way? Thank you, because it didn't pop up on mine. You do a little bit, but mostly it's paid by the organization. So I think for the medical mission I just went on, I think I paid $500, and that is everything. The plane ticket, all of our food, all of our lodging, everything. Because we do donations, and we have some pretty good sponsors for Faces of Tomorrow now. Because if you go on the website, you're gonna see all these pictures of like before and after the kids are. It's amazing. It's like they could eat, they could speak. We bring a speech pathologist and a dentist, and it's really special. Yeah.
Really.
And then send me the link. I will. And then kind of a little bit about RNA viruses, reverse transcription. I would make sure that you're reviewing that and do some study on that. And then there's straight replication, which uses its own template to make viral proteins and complementary strands. And then that's used to make more viruses. So it's all about replication, right? When it comes to viruses, which we just experienced. Like COVID started and then it went all across the globe. And then again, like HIV, Hep C, Hep B, herpes, which herpetic lesions and herpetic conditions are things that you'll definitely see in practice if you haven't already. And they can, viruses can adapt via that genetic mutation, which we started the night talking about genetics. So they're pretty scary. They're scary. So if you want to go into infectious disease, you're probably going to be studying viruses. Some examples of our RNA viruses. Some more, again, like, and then DNA viruses. So there's just Epstein-Barr is probably something that you're going to come into contact with. There's a lot more knowledge about Epstein-Barr and its impact on the body. So again, when you go down the pathway of not really understanding like what might be going on with the patient, it may be that they had an Epstein-Barr like acute infection, and then it's kind of like that latency of like the aftermath of what happened to the body. And people can stay like pretty sick. And then there's a virus case study. So again, in your study time, I would go through these case studies. I think they'll be really valuable for you. A bit on HIV. I think we know a lot more about HIV, and there are many people now. I was just listening to a show on NPR talking about how, you know, the majority of people are living like very happy, healthy lives now with HIV, which when we were younger, that was not the case. It's very scary. So while viruses are really hard to treat and manage, we also have humans that have like amazing brains that have managed to get us out of a lot of them through the creation of drugs and medications. And like PrEP will probably be something that you'll hear about if you work in family practice or in an STI family planning type of setting, because getting our patients PrEP is really important because it acts as preventative so they don't ever contract an HIV infection. So if you have people or patients that you run into that are highly sexually active, then getting them on PrEP is a really great service to them. Most people know about it, especially the teens and adolescents and college population, because they've done a really good like ad campaign, but important to know. And then there's a bit on like a fever of unknown origins, failure to reach a diagnosis despite like 1 week of inpatient investigation would be part of the criteria. possible explanations. These, I would say, like this whole section on fever of unknown origin would really be something that would be more in the inpatient setting that you would be managing. That's not, I mean, something like this, they're gonna be inpatient. So if that's your bread and butter and where you think you might be, then, or if a patient comes in and, you know, sometimes patients will come in having been sick for a really, really long time and knowing that that could be concern for cancers or for tumors or, you know, tumors that are cancers. And then colon cancer is something that unfortunately I've seen a ton of in family practice, and people do not want to talk about their food, is really what it comes down to. They don't want to talk about their food. So they will have blood in their stool for years and not say anything and know it's there because they don't want to talk about it. So it's our job to help them talk about it, right? It's really important for diagnosing and to know more about that. And I think we'll talk more about that in the GI portion. And then we kind of mentioned sepsis and urinary tract infections. And so these are like markers of sepsis. Those would be also things to know about and have a basic understanding, because sometimes on boards they'll throw like a sepsis question at you. And then like we were talking about, when your older patient, 65 and older, comes in and is like, yeah, I'm feeling a little dizzy, like it's kind of funny, automatic dipstick. Or like, I don't know, my memory is just a little off lately, like automatic dipstick. And I will tell you, most of the time, like I would say at least 80% of the time it's a UTI. You give her an antibiotic, you treat her, she's fine. You don't give her an antibiotic, she thinks she's fine, she goes to the hospital, right? So you guys have seen this, right?
Yeah, that is wild.
Yeah. And it's a UTI, it's like totally preventable. But like everybody's looking for it hurts when I pee. And that's not the case. Yeah. Sometimes you don't. Even younger patients, sometimes they don't. Yeah. Like any neurological or altered mental status, and particularly in our younger patients, right? They definitely should not have. I mean, unless they're doing extracurricular activities, they should not have an altered mental status. So these are some questions to kind of ponder and consider while you're doing your studying. So it's kind of like a think about these questions to help navigate your studying, which I think is really helpful because sometimes it's hard to just sit down with a textbook. So if you have any questions, you can definitely contact me via the University of Phoenix email, but actually my personal email is probably a lot better because I check that all day long. And then you can always, like I said, text me. I am seeing patients every day except for Thursday, but on Thursday I'm not in the clinic. My clinic days are long, so they're like full 10 hours. So if I don't get back to you right away, just know it's because I'm in clinic seeing people. And then make sure you complete the quiz for next week by 6 p.m. next week, so prior to the start of class. And then if you can, again, we didn't really get time to do the article because we spent the time on the introductions, which I wanted to do, but next week we'll kind of start the class with an article. So we kind of start to talk about like, how do we see endocrinology in the society, in the world, like of healthcare. And that should be super easy again. No more than 5 minutes. Should not take you. You can do it before class, like 5 minutes before class. You can look up an article. Okay.
Is the quiz that we're taking before next week? Is it just based off of like these readings and what we just all discussed?
Yeah.
And it's like a one-time shot, right?
Is it one time?
I haven't opened it, so I was like, is it time? As soon as I open it, go 15 minutes. Yeah, go ahead and share your screen.
You have 1 attempt in 15 minutes.
Yeah, I read that. So I haven't opened it. I'm like, it's gonna start for seconds. Yeah.
1 attempt in 15 minutes.
Okay. So yes, I will make sure. So I'm going to send a message out with the Google
Drive.
Yeah, Google Drive. And then I will post the PowerPoint before class so that we have it because multiple people asked. So I'll make sure that it's in the Google Drive. So just make sure that you have that link, like, and it'll be in messages. So you'll have access to it. Okay, so I'm gonna share my screen. My computer might start not working. I think it's just just not working.
It's okay, they actually found it, it was what, 15 minutes in one attempt, so,
Yeah.
so they're good.
So I would just say like, if you're just like, that was horrible, I can never do that again, what is happening? Then like we'll navigate that together, like we'll figure out, you have all the resources though. Like you have all the resources in terms of, if you're going through the animations, I would go through the animations, I would go through the videos. It really shouldn't take that long. I don't even think there's an hour of activities even if you do all of them.
It's just time though, that's what I think. How many questions is it? I didn't say the question.
I don't think it's,
Was it 10? Oh,
Let
okay.
me look.
Yeah, I mean, 15 minutes, 10 questions, we can do that. I just was like, is it like 45 questions?
No.
15 minutes? Like, what are we gonna do?
no, so for everybody online, we're looking, and my computer might crash, so we will.
Say goodnight. Is that what you're saying? Say goodnight?
Maybe.
Is there a study guide for every week?
So, no. Tom had like a template that he would, provide a template that he suggested they take notes, but everybody learns differently, so I'm not sure how we use that, but I think you can see
Okay.
the topics that she discussed tonight, so
There's 12.
12, okay.
There's 12 questions.
Okay,
And they look pretty reasonable.
okay.
So if this quiz, you all are like, that was hard and we didn't go over that, then text me or message me, and then I'll make sure that next week we really go over it, because I have access to the questions, so that way we won't have that issue moving forward. Because I mean, the most important thing is that you guys are just here, engaged, which everybody was tonight, so we will navigate that together. Any questions from people online before I close down?
Were you ask that? So we don't have to do discussion posts, right? Unless we're absent. Like
No,
way
no discussion posts, no discussion posts, everybody.
You know that would like stress all of us out.
No
for taking
discussion posts.
in-person classes.
Yeah, the discussion section, and I'm gonna change it, and all of them is the article.
Okay.
That's it.
You need to
So
be
just be
prepared
ready
to class
to
to discuss.
discuss in class. Okay.
I have a question. So when is the last until when I can do the quiz until next week before 6 p.m. on Thursday?
So look at the due date.
It's the 15th.
Yes.
Look in the grade book under the due date.
Right, the first quiz.
It'll tell you the title of the.
So the first quiz is due February, right now it's listed as February 15th.
Okay.
So next Wednesday is the 15th.
Is that,
we were doing with our last class,
Oh,
was
yeah.
the day before.
yeah, so it'll be Wednesday by midnight is what it's listed as.
Okay, thank you.
Melissa's gonna just fix some dates and then change the discussion to participation, so.
Yeah, but we'll leave the quiz, I mean, I think is that okay with you guys? Yeah, and that quiz is related to this week's material. Because that was a question too. For Marlena.
Will you send the link that you sent earlier?
I already sent that. That should be sent as a message, yeah.
Thank you.
Yeah. Okay, I'm gonna close this part down and you guys have a good night and let me know if you need anything. And that's it.
I just want this assessment.
Thank you.
Thank you.
Oh,
Next week.
I can- this was like-
No, it's the